It's quite a difficult topic, and I'm sure many of us have had patients who um, have come back to us after 3 years or 4 years after surgery, and whatever treatment we give, they are very, very miserable with pain. So, just to give you a background, we all know that chronic pancreatitis is progressive inflammatory disease, and surgery is often indicated for intractable pain. The different options we have are either resectional or drainage procedures, and the different types of resections we do are either head resections or a Whipple, and the drainage procedures are either a Frey or a Bager or a burn procedure. So what we are trying to talk about today is trying to define surgical failure. Of course, there are different types of failure. It could be postoperative failure in terms of complications or needs for reintervention or alternative therapy. But today, most of what we're going to discuss is persistent or recurrent pain, because that's the commonest indication for which we do the surgery. So if it fails, usually it comes back as severe pain. So what is the incidence? There are 2 or 3 recent papers, long-term survival outcomes after operative management of chronic pancreatitis, published recently in the American College. So here you can see that in long-term follow-up, about for 300 patients, 26.9 were opioid dependent within 4 or 5 years after the operation. So another paper here is published in 2022, 40% of patients had pain persistence. So there is clearly a significant number of patients in high volume centers, which after 5, 6 years, you start getting chronic pain. So again here, there was a consistent worsening of global pancreatic function post-surgery. So that also seems to be pretty routine, but obviously those are medical issues and they can be controlled with medical therapy if there's exocrine or endocrine dysfunction. So here you can see that again, though pain and quality of life scores are better in even assessing functional outcomes, you still get worsening exocrine and endocrine function. So that seems to be not a surgical issue. If there is worsening endocrine and exocrine function over a period of 10 or 15 years after your surgery, those can be managed medically. So let us see now which surgeries are more likely to cause problems. So if you try to do the old lateral pancreatic angiostomy, I remember I gave a talk about 8 years back in an ISG, is lateral PJ dead? So I think one of the reasons why lateral PJ alone is no longer done is because almost a third of patients develop pain very, very quickly. Pancreatic duodenectomy is good for pain relief, but there's very high postoperative morbidity and has been mostly abandoned as a routine procedure for patients who have got pain in chronic pancreatitis. Distal pancreatectomy again is used for only a very specific kind of indication, and it's there again the morbidity rate is high, POPF is high, and some element of pain comes back if the main duct causes problems in the future. Frey procedure seems to have the best long-term pain control. So here it is, it says 90 to 93% long-term pain relief, but as I said, if you study these patients carefully after 8 to 10 years, a significant proportion of them, maybe a third of them, do get pain. So from all these procedures, perhaps the least number of patients who get pain is after a good, well-done Frey's procedure. So anytime you see a patient upfront, you should try to do a good Frey procedure, and we can see how to try and do that. And again, in patients, risk factors, alcoholism and preoperative analgesic medication use are the 2 important risk factors which determine recurrence of pain. So again, alcoholism is very important to counsel these patients, especially the alcoholic ones whom you're doing, to make sure that they've got adequate counseling before you do it and after the operation is done and when they've got pain relief. The other risk factors for persistent pain or recurrent pain and predicting failure of your surgery is preoperative daily opioid use and high numbers of preceding endoscopic procedures, as mentioned by our first speaker. So that is the whole logic of trying to do early surgery in the ESCAPE trial. So again, in the ESCAPE trial also they've shown that patients who undergo surgery after many procedures are the ones who are more likely to have recurrent pain. So overall, the evaluation of pain would be to obviously take a detailed history. One of the important things, as Dr. Ramesh mentioned, is that they could be having a malignancy. So the pattern of pain, any change of pain in the post-operative situation. So again, you have a patient of chronic pancreatitis, so monitoring these patients for pattern of pain, opioid use, if they get recurrence, alcohol reuse, and of course obstructive jaundice. So many of the patients that we've operated 3-4 years down the line, if they get obstructive jaundice, you must strongly suspect a malignant change in the chronic pancreatitis. Examination, nutritionally, if they've gone down or not, lab investigations, tumor markers would be especially important, both CA and CA19-9, and contrast enhanced CT. So we've had, in our own series of patients, we've had some patients with rule-loop problems, which I'll describe. And an MRCP, sometimes if the patient has got just pain, especially backache or a similar pain related to the original pain that the patient had prior to the operation, an MRCP may be useful. So here you can see that we have tried to analyze what could be the causes of the recurrent pain and how you could manage these. In all the published data so far, the redo surgery needed is about, depending on which series it is, between 1 and 23%. So you must evaluate these patients carefully, because about a fourth or fifth of them with re-operations can get relief of pain. Majority of them, 3/4 of them, are not going to get relief of pain after re-surgery, but with careful evaluation after an LPJ, ensure that there's a good, adequate drainage of the entire head and body of the pancreas. After a Whipple resection, a stricture of the pancreatico-jejunal anastomosis could be a problem, and after distal pancreatectomy, the persistent remnant could have more gland disease. So surgery can be required, and it can be in the form of either resection or a total pancreatectomy. So the East has got a different view compared to the West. The American data suggests that the preferred method is usually a total pancreatectomy. And as you can see here, the revision surgeries in these groups of patients, where you can see that either if a PD or a distal pancreatectomy or a pusto was done, the number of patients who had a total pancreatectomy is much higher than the ones who have undergone revision procedures or revision drainage procedures. So their Western data seems to suggest that patients with persistent pain after surgery, total pancreatectomy is the preferred option, especially those who have not responded to further medical or endoscopic treatment. This is, Dr. Ramesh has kindly lent me his data on the number of patients they've reoperated in a large series of more than 1,000 patients, where you can see here that in patients who've had a fray, about totally 63 patients were reoperated. And you can see here that LPJs were converted to fray, or a fray required, say, with obstructive jaundice, choledochorduodenoscopy, or a recoring, or a distal pancreatectomy. And this could be after careful evaluation of these patients. We've had published a paper with 6 patients who had a problem with their Roux-loop. So with the Roux-en-Y anastomosis, you can see that you can have, with a careful CT with intermittent pain, especially associated with vomiting, most of the patients present with intestinal obstruction, but it can be sometimes confusing because this is intermittent obstruction. The patient settles down with conservative treatment and then comes back again with recurrent episodes of severe upper abdominal pain associated with vomiting, which may not be there with just recurrent pain, which is due to chronic pancreatitis. So carefully evaluate them with the CT, and we found 6 out of 140 patients who had Roux-loop issues, and with surgery, they all got better. Now, is it safe? The next step is that if you do need to operate these patients, luckily, it seems that the number of patients who have got morbidity is quite, almost 15-20% higher, but the mortality rate is very much similar to if you're doing it upfront surgery for the first time. So therefore, it's worthwhile considering these patients for reoperative surgery, because though there is an increased risk for minor perioperative complications, the overall complication rate and major complication rates are very similar. Just like how you repair bile duct injuries the second or third time, the morbidity seems to be higher, but long-term results are very good. So there's good evidence for resection, for reoperation, and it is therefore important to assess these patients carefully. So you can see here there are small papers on 3 or 4 patients where they have found that LPJ done 10 years ago, there was pancreatic duct disruption in one patient. LPJ done 7 years ago, there was a completely stenosed LPJ with a stoma, which was just a pinhole. So it's really very important to analyze these patients, and the best way to do it is with a CT or MR, depending on what kind of symptoms the patient has come with. So considering reoperation, suppose you do not find on imaging that there is any reason to offer resurgery to these patients, which is in the majority. The 3/4 of these patients are not going to be amenable to reoperation. You can think of other methods by which you can treat them. Unfortunately, most of these methods are really not very helpful. Either a celiac plexus block or a neurolysis or a thoracoscopic splanchnicectomy which I've done a few of, and it reduces the pain for a few months, but most of these patients come back with as bad pain as they had immediately after the surgery. So managing beyond the pancreatic duct is what most of these people are calling this kind of pain management. Methionine-containing antioxidants could be one way to do this. So if you try a kind of algorithmic approach, if you have recurrent or persistent pain after surgery, you can look for ductal obstruction and do post-ductal clearance and see if the patient gets pain relief, or then try methionine-containing antioxidant micronutrients. These in small randomized trials have shown to be of some benefit, but again, these long-term studies are not available yet, so it's important. It's difficult to give a real answer as to whether these are going to work in the long term. So if there's inadequate response to ductal decompression or inadequate response to methionine and there's a recurrence of pain, evaluate for ductal obstruction, see if it's present, treat accordingly with further surgery, or if it's not amenable to any surgical treatment, you have to try either pregabalin or other combinations of SSRIs and celiac plexus neurolysis in combination. Just a few examples of these patients who have come back a few years later with recurrent left-sided pain. This patient had a undrained left duct system. You can see that the entire, there's a stricture here, and the pancreaticojejunostomy has not drained the distal segment, and this patient really benefited from further drainage of the entire tail. So here you can see that the head duct has been opened out. This was initially Partington-Rochelle operation was done and the head was left undrained. So you can see here that the same rule loop is being used. The rule loop has been extended and fresh anastomosis has been done to the. Here you can see that the head has not been managed, it's untackled, and you can see that there is air in the pancreatic duct. So there's a good LPJ here, but the head is completely undrained and untackled, and this is a patient very amenable to reoperation. Here you can see that again the head was opened out and after cauterization, and the head was drained into the same rule loop. So again, as I said earlier, can surgical failure be prevented? So it's important to try and see when you do the first operation that you try to do a more complete head coring. So perhaps a sentinel stone removal, inferior part of the head below the main duct, and intraoperative C-arm conformation are the methods by which you may improve your ductal clearance and your initial drainage so that you try and reduce the patient's recurrent pain. Because once it does occur, it's a very, very difficult problem to manage, and it's a real challenge in trying to get these patients better. Thank you very much.